Welcome back, legends, to the Sports Medicine Project. Now, as always, a very exciting guest. Kelly and I are talking with Dr. Ebonie Rio. Ebonie, how you going?
I'm great. How are you?
We are going really well. Now, we were just speaking off air. Your bio is pretty big, so I'm going to try and summarize it as best I can. And correct me if I'm wrong, and feel free to add anything. So you've got 4 degrees, postdoc researcher currently at La Trobe, and you've completed your PhD in tendon pain. You've also got a master's in sports physio and also a Bachelor of Applied Science. And you've worked with like the Australian Institute of Sport, the Australian Ballet, Melbourne Heart Football Club, the Victorian Institute of Sport, Commonwealth Games, the Vancouver Winter Olympics. And correct me if I'm wrong, you spent 18 months traveling with Disney's The Lion stage show. Is that right?
I did, which took me to Shanghai, which was super fun. And yeah, no, I've been really lucky. I've had some pretty fun physio experiences, actually.
Yeah,
Yeah, it sounds
that's
like
interesting.
it.
Yeah, that's cool. That's really good. So before we get started, what's kind of been your journey from kind of as a first year new graduate as a physio to where you are now? Because Kelly and I were even speaking about it this morning on our run. We were talking about, we've seen you present and speak online, and you're certainly quite a very prominent voice on tendons in Australia and the world. How did you get to that point?
Oh, okay, good question. So when I finished physio, I I'd completed my honours actually with Professor Jill Cook, and she said, "Oh, I think you should consider doing some research." And I said, "I don't want to do research. I want to help people." And she said, "If you're a physio, you can help the person in front of you, and if you're a researcher, you can help many." Now, she doesn't even remember saying that to me, but I've quoted this back to her. But I went, yeah, I want to go and be a physio. But I didn't really know what I wanted to do, to be honest. And I also felt like I knew nothing. So I threw myself into everything. So I worked at Monash Medical Centre as a new grad, which I loved. I loved neuro. I volunteered at gymnastics with the elite program. And I also was a sports trainer on the weekend, and just I loved it. And I just got a lot of really good experience. And then after quite a while of doing that, my a friend said, why don't you do a little bit of private practice? So I started a little bit of that just to get my confidence. And then I went for an interview with the Lion King, and it was so weird actually, guys, because I thought there's no way they'll pick me. But what I realized is how important, personality and communication and those things are, because people that aren't in sports medicine assume that all physios, can physio. So they actually weren't that interested in my sort of clinical reasoning or clinical skills per se. They just wanted the right person, and they picked me, and I had a ball. And then that also led me to some amazing opportunities. I had a dancer with posterior ankle impingement, and I had no idea what to do. And so Dr. Andrew Garnham said, well, you need to go to the Australian Ballet and learn from Sue Mays. And Sue Mays, not knowing me from, a block of soap, took me in and taught me all this stuff. And I'm like, what an amazing profession, what's in it for her? Anyway, what's in it for her? I've ended up, I work there now. So, it's
Yeah.
worked out really well. But yeah, I then sort of went back and did some research stuff and did my PhD, and I found myself in tendons because they were the tricky injury in basketballers that kept me awake at night. So it was a
Yeah.
clinical interest. Yeah.
Yeah. Wow. It's a pretty incredible journey, and I'm sure a lot more to go. Hopefully, I've got my
I
fingers
feel
crossed there is.
my like the biggest takeaway that I just got from that, Ebonie, is like there's so much value in just saying yes to everything. Like Blake and I talk about this all the time. Like there's times when you maybe don't want to go help out with some sports training or go and present to a particular group. It just doesn't fit in with your schedule. But by the sounds of it, you've just landed yourself some amazing opportunities by just taking anything that sort of comes. And I think that's cool. That's probably a lesson I need to learn.
I think you're so right. And it can also mean a little bit of a point of difference. So for the Lion King job, I would not have been the most experienced physio, but because I'd worked in like local footy, they knew I could manage, emergency situations. I'd worked in gymnastics. They knew I could manage bendy people, so the combination of skills, and they were all volunteer, actually did lead me to something like that. So I think you're right. Just say yes, and you never know where you'll end up, but it'll be fun.
I like it. I like it. Now, one of the questions, and we'll put the first one of the, I would say the hardest question, or maybe the answer we're most looking forward to. And certainly, I don't know if I'm biased because I've seen a lot of it online in the last couple of months, but it was something that had changed in my mind in the last 3 months, where I thought that everyone with tendon pain, and that's how I would almost treat clinically, everyone with tendon pain needed heavy slow resistance or heavy training. And there was that study that came out, I can't remember the author now, that compared medium loads to high loads and found roughly no difference for like function and pain. And now everyone's kind of on the other side, where it's like they just need consistent load. And it kind of leads us to our question of what changes for a person when they move from pain to no pain in tendinopathy. And I guess the follow-up to that would be, what can we tell our patients that we are changing on what we're trying to work on, if it may not be strength or stiffness or that kind of thing?
Yeah, wow. So I think that there's a couple of really great points in there that you've made. And the first thing that I want everyone to get their head around is there's no single exercise or single mode of contraction that is the answer for tendons. So all of our different muscle contractions have a role, but so does the rate of loading. So tendons are like a spring. So a heavy slow resistance or an eccentric program or isometrics will not return someone to capacity or to function, because tendons function as a spring. So we've got to make sure that we don't go, should we be doing X or Y? We shouldn't be so black and white. We should be saying, for the person that's in front of me, where are they at? Are they in rehabilitation? Okay, I've got to take them through addressing what strength deficits they do have and then retraining their spring. If I'm in season, what evidence do I have that are safe loads in season? So I think what we think we're changing in humans with tendon pain is a combination of stuff within the tendon, so they can measure some stiffness and some mechanical capacity. We're changing muscle, strength and endurance. We're definitely changing neural drive. And based on when we look at that stuff, you'll get a different answer. So tendons are really slow to change, but they're actually quite responsive. The central nervous system's pretty quick, and muscles are sort of somewhere in between. So if I look at something at an immediate effect or 4 weeks or 1 year, all of those systems alter, but they probably alter in different amounts. Does that make sense?
Yeah, that makes a lot of sense. I never heard it explained like that. Is it with like the heavier loads, and I think, and I feel bad now because I can't remember the author's name, where doing loads over 90% is a pretty good way to increase the tendon stiffness. Do we have to have that for someone to be able to get back to running or soccer and that kind of thing? Like, do they have to have those heavy loads?
Yeah, Blake, it's another really good question. So I think one of the things I'd really encourage everyone to do is work out how to integrate evidence without sort of disregarding everything that's come before it. So what we're really guilty of doing in sports medicine is a new paper comes along and we disregard everything before it. So, and we see examples of that repeatedly. So what I'd say to people is there's a couple of key things. We know that people have unilateral deficits if they have unilateral pain. So I say to people, I use heavy slow resistance, but I actually don't use either of the published protocols because they're both double leg. And as humans, we actually do things on one leg at a time. So what I do is I take the research that we know people have asymmetries, but then I layer on heavy slow resistance activities and prescription, but in a single leg way. I also then incorporate the concept of cross-education, where we know that if you strength train one side, you actually transfer some strength to the other side. So I've used 3 bits of evidence to come up with a really individualized program. And the 4th one I'm going to add in speaks to your question of stiffness. It's a fantastic systematic review by Bohm. I think it's BOHM. And they showed that strength training with lots of different levels of MVC is effective for improving stiffness, but plyometrics are not. So the key thing was actually around, so isometrics and isotonics were both effective. So I think we change a lot of passive structures and active structures in our muscle tendon unit when we do weight training. And I don't think there's one way of getting there.
Yeah.
Did I answer your question?
Yeah, no, you did. And that's all. I guess there is never any black or white, and like you've always said, it's very individualized to the person in front of you, and probably most things we do are probably going to get there in the end if we do it consistently enough.
Consistently and progressive, absolutely. So my guidelines or my recommendations would be, don't try and be functional to begin with. Isolate the deficits that you find in the kinetic chain and then worry about putting it together as a functional unit. Do things single leg but each leg, and push each leg to their own ability so that you drag up the weaker side quicker and you reach symmetry, but don't stop there. Progress to retraining the spring. So really understand the demands of the sport or the goals of the athlete. And an example would be, for a jumping athlete, they need to be able to leg press, 1.5 times their body weight on each leg before we'd consider, some jump landing kind of training and some more plyometric work. So they've got the capacity.
Yeah. Yeah. And following from, I guess, like talking about the rehab and what clinicians are prescribing to the patients in front of them, is there a reason why stretching has been somewhat discouraged in tendinopathy, and especially the Achilles, depending on if it's insertional and the tensile load compared to mid-portional? If stretching is still a tensile load, could you say it's just another form of load, but just a lower level, and that could be a stepping to then bridge to, say, isometrics and so forth, or is that not the case?
Oh, another good question. So one of the reasons why I love it. So one of the reasons why stretching is quite provocative for us is that all of our tendons, bar the mid portion, happen at a bone tendon junction, and the bone tendon junction is what compresses the tendon. So compression doesn't cause tendinopathy in isolation, but once we have a sore tendon, compression is a really provocative load that we look to remove. So what we're doing when we stretch our insertional Achilles is just compressing the tendon against the calcaneus. And that's why people with insertional Achilles don't like being in bare feet, because they get into compression sooner. They prefer to be in a shoe with a high heel. It's why people with hamstring tendinopathy, we take them off a deadlift, but put them on a prone hammy curl so they're out of compression. And I'm not sure what the benefit is for stretching a mid-portion Achilles as to what we're trying to achieve. So I'm not saying we should or shouldn't do it, but to answer your question around our other tendons, it's because it applies a provocative compressive load as opposed to the tensile load, actually.
Yeah.
What would be the clinical reasoning then for something like shockwave on an insertional Achilles tendon if there is quite a lot of compression happening with that?
Oh, you'd have to ask someone that uses shockwave. I don't use it. We did some research that looked at the impact on the tendon, and you do get a tendon response. There's also been some research in Shetland ponies actually that showed that the tendon has a response to. Sorry, there's a fire truck that's decided it's going past right now. So there is a tendon response that we can't say is positive or negative. There is a response. The actual rationale, Kelly, is probably around trying to reduce nociceptive activity. So trying to actually change pain drive or nociceptive drive as opposed to a structural change in the tendon. But it's not a technique I use, so I'm probably not best placed to talk about it.
Yeah, I was going to mention this offline. A colleague of mine actually opened up a clinic with Kian up in Port Macquarie.
Oh,
And I
yeah,
think,
great.
and
Yeah.
yeah, and he was talking about Shockwave last week and saying, yeah, it may not be as good as what we once thought it was in regards to, I can't remember what he was saying, changing some of the stiffness or the pliability of the tendon, but it was really interesting. I'm going to see him tomorrow, so I have to talk to him about that. Do
Yeah,
you
definitely
find
ask.
people like get a good response, or have you heard of people getting good responses with Shockwave?
So it's one of those techniques that you can find as many people that swear by it as many people that say it didn't help. And I'm really honest when I talk about this. I see the people that don't get better. So I
Yeah,
see the people that have tried all of that stuff and hasn't helped. So that makes me really biased to going,
yeah,
well, it hasn't helped. Equally in the research, you can find as many papers say it's the best thing since sliced bread as many papers say that it doesn't work. The Dutch, led by Professor Hans Werver, did an excellent in-season study on patella tendon where they also compared sham shockwave. So you can still get like the noise. The shockwave in itself is
yeah,
painful, so it's probably not a perfect sham. But it probably creates some sort of diffuse, noxious, widespread inhibition for a short period of time. It's a technique that I would say, and I hope no one uses it like this. You can't use stuff like that in isolation. That's the
yeah,
first thing, because we know that loading is the cornerstone of management because we need to improve people's, function and capacity. The second thing that I'll say is just be really thoughtful about the message to your patient or your athlete. Are you saying that you're fixing the tendon? Are they thinking there's something broken or wrong that needs that intervention? So the way we frame these interventions can also impact what people think they need to do about it. And so I use exercise as the cornerstone because the message is really clear. That's what we need to do better, and this is what you can do about it, and this is how I can help you. So I don't use a lot of passive therapies for that reason.
Yeah, that's fair. And I would say Blake and I would probably be very similarly aligned in that regard. I would love to pick your brain, Ebonie, about tendon pain. Like, what is it? Why does it respond in the way that it does? And why does it have that warm up phenomenon and then talk to us in the 24 to 48 hours after? Do we know the answer to that, or what's your sort of best guess or theories? I find that very interesting.
Mate, that's why I did my PhD on it. I wanted to find that out. And then we actually met up with some really clever ion channel scientists, and they said, but we actually don't know the nociceptive driver in most musculoskeletal pain. And it's true. We don't really understand why some people have pain with OA and others don't. We don't really understand patellofemoral joint pain. We're much clearer on the acute injury. Someone sprains an ankle, someone ruptures an ACL. We're much clearer on the pro-inflammatory cytokines. We're much clearer on the ion channels that are involved. But we actually don't know as much as we think, as I thought we did, on things like tendinopathy, and it's not in isolation. So we don't know what the nociceptive driver is. That's the first thing. I've got some really nerdy theories. And if anyone is as nerdy as me, we wrote a paper called The Pain of Tendinopathy, Physiological or Pathophysiological. And my husband calls it the cure for insomnia. He couldn't even get through the abstract. But bear with me. I know, so rude. Okay, bear with me. I'm going to give you the short version. So there are different ion channels and receptors. So the ion channels are our sensors. So they sense the chemical environment and the mechanical environment, and they give the information to the afferent nerve or the nociceptor to come up to the spinal cord and brain. So they collect the information. There are certain ion channels that are present in, tendon and bone and cartilage that we think are quite important in driving that nociceptive stimulus. And the warm-up phenomenon could be, Kelly, that some of these ion channels actually get saturated. So what happens is they're open, and then they're like, mate, I can't take any more. But then as they close over that 24-hour period, and you get up the next day, you're like, whoa, that's a bit sore, because all of those substances are still kind of present. So we don't know the answer, but there's definitely some potential, reasons as to why that's the case.
And so then in that initial question that Blake asked, in what happens when someone is out of pain in tendinopathy, do you have a theory maybe that it has a similar, it may be something similar with the ion channels and the substance saturation maybe not being as prevalent as when someone is in pain?
Well, actually, we have the capability of turning over our ion channels. So I would hypothesize that as we adapt our human over time, that we actually produce fewer and fewer of these ion channels to stimulate. But we've got absolutely no idea. So yeah, we actually don't know, but we clearly change a lot of things in the brain, spinal cord, muscle and tendon with recovery. But we also know that tendon pain can come back, and that could be related to some of the neuroplastic or neuroplasticity or maladaptive change in the brain that we see that could actually increase our risk of recurrence. But, there's so many cool research questions that you're asking. So I'm just wondering when you two are coming and doing PhDs with me. Brilliant questions.
This is our dinner conversation every night, and especially leading up to this podcast, Kelly and I are like, we need to try and get really well versed, and the questions need to be, because these are the questions we ask, and we obviously don't know. So it's it's great to hear those.
Well, it makes you feel any better. No one knows. So I'll tell you a funny story. I did have a patient once, this is years ago, and he said to me, what causes tendon pain? And I launched into this fabulous, very well considered, well, actually we don't know. And he said to me, have you tried Googling it? And I was like, oh, that's where we're at.
Funny. Have you checked out Twitter? She said, just check out Instagram and Twitter. The answer's on there somewhere.
Someone on Twitter will know the answer for sure.
What is your simplified answer that you would give to patients when you're explaining to them why they have tendon pain, or what is tendon pain?
Yeah, so I say to people, we actually don't know what information. We don't know why your tendon's sore. What we know is you seem to have done more than what it's capable of, and that's when it gets a bit grumpy and it gets quite sensitive. And then, unfortunately, what people tend to do is unload, and the more you unload, the lower your capacity is. And then you get into this risk of kind of relative overload, where I don't think I've done too much, but I've done more than my new capacity. And so I show people that sort of that spiral that we see clinically. So I say to them, we have this sensitive tendon, but we also know that tendons love slow and static load. And we've just got to take away some of the loads that are springy or compressive, so the high tensile load or the compressive load in the beginning. But we need to get you back to that, because that's life and that's sport and that's function. So we're not going to stay away from that stuff forever, and we're not going to rest. So I frame it in a really functional way, because I don't think the key things that I want people to understand, if I'm honest, is that it's not inflammatory. Because if we're saying tendinitis, or we're thinking that inflammation underpins their pain, then you could write the world's best exercise program. People aren't going to do it, because there's a disconnect between what they think they need to do and what you're offering. So don't allow people to say tendinitis. Correct them and say, actually, we now know that it's really different to spraining your ankle or straining a muscle where you have that inflammatory process. There's lots of little communication molecules, and there's lots of stuff going on, but it's not inflammatory. And we know that exercise is really important for tendons. So I frame it in a really functional way, Kelly. I don't get bogged down in the physiology, because I used to talk to people about tenocytes. We don't even really know their role in pain. We understand a lot more about the pathology, but people can go through that whole pathological process without pain. So we don't know as much as we think we do.
I've heard you. Sorry, Blake. while we're talking on explaining things to patients, I've heard you explain in a really nice way, like calcification and Haglund's deformities before. And I would love to hear you sort of share that for our podcast as well, on how you would explain that to a patient and how it forms, and just sort of a nice way to de-threaten it to patients.
Oh, I'd be delighted. So I'm going to start with Haglund's. So Haglund's are morphology. They're not a deformity. Please don't use the word deformity, people, because it's just a different attachment of your Achilles into your calcaneus. So what can happen is you can either have a big, fat, or flat attachment of your Achilles into your calcaneus where there's a really big surface area, or you can have a smaller area of insertion and then you have a different emphasis or a different insertion. So you'll have a retrocalcaneal bursa, you'll have a Haglund's, you'll have just a different structural adaptation in that area. And so they're just two different types of attachments. So the Haglund's provides a mechanical cam. It's actually a mechanical advantage. I have two of them. And because the tendon will actually lever off the bone and provide that mechanical cam. And so we don't need to chop it out. We just need to manage them like an insertional Achilles, like they are an insertional Achilles. The problem is the compression as they go into dorsiflexion. So they don't need to be removed. They're completely fine. And in fact, if you chop them out, what you've done is you've left that tendon vulnerable because it doesn't have the normal surface area of the other tendon insertion. Does that make sense?
It does.
Yeah.
So our Haglund's are totally fine. It is not a diagnosis. It is an anatomical, I don't even want to say variation because I have two of them. So I'm going to call it's normal. It's so normal. So Haglund's are fine. They're to be celebrated. When we're thinking of calcification, this is exactly how I would explain it to a patient or an athlete. I would say, okay, I want you to imagine you're a cell in your body. If you're a cell in your body and you're seeing lots of lovely tensile load, you're acting like a spring, then you're a tenocyte and you make tendon because your environment dictates what you are and what you produce. It's bidirectional. If you're a cell in your body and you're exposed to lots of lovely compression, then you're a chondrocyte and you make cartilage. So that's the lining of our joints. If you're a cell in the body and you're exposed to lots of spring load, lots of high tensile load and lots of compressive load, then actually the best tissue we have in our body that can deal with both of those is bone. So what we can see is some calcification or some sort of harder substances within your tendon, and that just tells me you've loaded your tendon over time. It tells me you've done lots of combination loads. We don't need to chop it out, and actually you're going to do really well with rehab. There's nothing that changes about our management plan because it's in there. All it tells me is you've done lots of lovely load over time. Let's go for it.
I love that. That's awesome. That's so good.
And that is all backed by science. Like that's not just me talking crap either. That is all 100% distilling science into a message that, as you said, Kelly, makes it non-threatening. Because if I'm seeing bone in my tendon and no one's told me that's okay, I'm a bit nervous about that.
Yeah, and nervous to load it as well.
Yeah, absolutely.
Yeah, I like that. I like the mechanical advantage part. I feel like I need to get some Haglund's. I'm trying to get under 19 minutes of my park run. Maybe the Haglund's might get me there. Make my tendon a bit springier.
If you had two Haglund's like me, you'd be all over it. You're just going to have to train harder.
That's like a form of doping.
I love it. Oh my gosh, I'm going to use that. I love it. My Haglund's are a form of doping. I'm going to put it on a t-shirt.
And would that be, is it similar with, and I actually had this question this morning with someone that they'd been dealing with a unilateral mid-portion Achilles, and they were just asking why it felt thicker, and noticeably it looked thicker. Is it similar with how you're saying, like it just like how you get callus on your hand or callus on your foot, if you're exposing it to that load, it gets thicker to get stronger when people have a thicker tendon?
Again, I can give you some science on this. What a great question. So Dr. Sean Docking, who is a brilliant researcher and a really good friend, so I'm 100% biased, he looked at Achilles and patella tendons of people with pathology, so changes in your tendon, right? And he found that people that had pathology in their tendon had a thicker tendon, which we know we see clinically, but actually what they had, this is the critical bit, they had more load-bearing tendon, so tendon capable of taking load around the pathology than someone with a completely normal tendon. So I'm going to say that again. Your tendon absolutely adapts. If we're talking patella or Achilles, we should be looking at their tendon and go, look at your big, fat, fabulous tendon. That is bioplasticity right there. That is adaptive. That is fantastic. And you know what? That makes sense, because if pathology always overwhelmed the tendon, then everyone with tendon change, we'd see far more ruptures. Clearly, the body has a mechanism for adaptation. Now, this is not the case in every tendon. So we do see tendons like our tib post, and for example, the supraspinatus actually doesn't get thicker. But we see tendons like our tib post that as they get changes over time, they can lengthen and they don't necessarily thicken. So if I'm using science to reassure people in and around the patella and the Achilles, then I do. But yeah, that's why you have a thicker tendon, because your body's done a fantastic job. Well done you. As Dave Butler would say, you good little self-healer. Fantastic.
And what was that with the tib post? So that doesn't change in thickness, it lengthens, is that right? As it changes?
Yeah, so in our predominantly women, but not always, that end up with that sort of flat foot deformity, it appears like the tib post doesn't adapt in the same way, but it also has a really different role. Like if we think of our Achilles and our patella tendons, they have a real agonist role in moving. The tib post is a synergist for plantar flexion, so it has a really different purpose. But what we see is it appears that it sort of lengthens over time as opposed to thickens and has that adaptive response. You know, glute med would be similar. Glute med has a different kind of pathology, but you know, having said all that, exercise actually remains our most effective treatment for all of our tendons, almost regardless of the adaptation or perhaps lack thereof in that particular tendon. It still seems to be about improving function.
Yeah. And talking about like the changes that we see in tendons, and I only found this out recently that in the late 1900s they used to cut tendinosis out of people because they thought it was pathological, and then not seeing anyone improve. And talking about tendinosis, is it similar to like age-related change with arthritis? Because a lot of the time people come in clinically where they've had an ultrasound of their tendon, they've got Achilles and tendinosis. It's like, great, you know, I can see this tendinosis. This is what the imaging says. Is it similar to arthritis where it's kind of normal and like age-related change, and it's very possible that you have that 5 years before you had any of this tendon pain?
So it's very likely that they had that pathology first, and we do see a lot of asymptomatic pathology. So I've got a couple of key take-homes out of what you just said. The first thing is that tendinopathy is a clinical diagnosis. If you're not thinking tendinopathy and someone comes in with their scan, you need to reassure them that these asymptomatic kind of changes are load related. And I'll give you some examples and ways to explain that. So imaging should not change your diagnosis with tendons. That's the first thing. It's got to fit the clinical picture. The second thing is Kevin Lieberthal did some fantastic master's research that showed the difference between people that had changes or pathology or tendinosis in their tendons and people that didn't was how long they'd been running. So if you've been running for longer than 7 years, you were more likely to have changes in your tendon. It is a load-related change. And the reason why we might see it and assume that it's related to age is you've just had more capacity to load. But it actually wasn't age per se, Blake. It was actually load. Yeah. But we don't need to be talking about it as wear and tear. Like, this is a load-related change. You've got a thicker tendon. Keep running, fantastic. If they have some tendinopathy, let's work out how to get them back to running. Running's fantastic. So let's, de-threaten how we get them back as well.
Yeah. So that makes, rather than calling it, and I'm guilty of that, of course, calling it age-related change rather than load-related change makes a lot more sense, and I think way less.
But we also don't want to make people fearful. Yeah,
to load
no,
it,
you're right. We also then don't want to make people fearful of the load. That's right. So we want to make sure that that is an open conversation.
Yeah.
But age-related change makes it sound inevitable. Sorry, go.
Yeah. Sorry, I was just thinking, I had a patient that came in and saw me recently after a tenotomy, and I hadn't seen someone with a tenotomy in a very long time. With some of the chronic cases that you often see, Ebonie, do you ever see like a place for tenotomies, and when or why?
Oh, I've not seen a tenotomy in 20 years, mate.
Yeah, I hadn't either. I was surprised.
Okay. Yeah, no, I have not seen a tenotomy in a very, very long time. So, I wouldn't understand what the clinical rationale was for that, but I also don't know the patient.
I couldn't either.
Yeah, interesting.
Yeah. Do you ever have the case of like injectables? I know we spoke to Peter Meliaris a couple of months ago and asked him the questions around injectables, especially for the Achilles, and he was saying, there may be a case, certainly not in the tendon, but there may be the case sometimes and rarely for around the tendon. Do you share a similar idea, or do you ever have that case when you see them clinically, especially in the chronic cases?
Yeah, so the first thing to say is it's worth differentiating between conditions of the peritendon. So the peritendon are the outside synovial layers that slide and glide over a tendon. Now, we don't really understand the pathology. As best we know, it's inflammatory. What we do know is it's really different to tendinopathy. So someone with tendinopathy has focal load-related pain associated with using their tendon like a spring. People with peritendons present very differently. They don't warm up. They get worse the longer they go, because as they go through range of motion, that's their provocative load. They have quite diffuse pain, and they respond terribly to a tendinopathy program, because if you give someone calf raises, that is their provocative load. So you might see it if they're a cyclist or a swimmer, someone that uses their plantar flexion and dorsiflexion repetitively. But the ones you don't want to miss actually are the runners that get worse the longer they run. So as you start running, if you ground strike in a sort of quasi-isometric way, then you're not putting your peritendon through a lot of range. But as your calf fatigues, if you start to go through much more plantar flexion and dorsiflexion, you start to overload the peritendon. So just to summarize, peritendons don't have that warm-up phenomenon. They tend to get worse the longer you go. They tend to have more diffuse pain, and they need to be managed really differently. So we have and do use cortisone in a peritendon condition. At the same time, or alternatively, we might use the creams. So we'll work with the doctors. So there's half iridoid, half Voltaren, and that actually treats the crepitus or the irritation between the tendon and the sheath. At the same time as that, the critical thing is reducing their provocative load, which is movement. So for someone with the Achilles, you might put them in a shoe with a really high heel, but I'm going to take them off all their calf raises. They do terribly with isometrics. It bunches up the peritendon and it really provokes them. So anyone out there that's got Achilles tendon that's provoked by slow or static loads, just have a little bit of a consideration that it could be the peritendon, and you can listen to the crepitus with a stethoscope. Sorry, I went off track there, but I wanted to make the point that is a clinical justification for cortisone around the sheath.
Yeah.
When you talk to Hock and Alfredson about cortisones around the sheath, the cortisone does make it into the tendon. So he's a surgeon. Everyone will know him as the like godfather of eccentrics, but he's also a really, really skilled surgeon and came up with like the stripping technique and stuff. So he's really against cortisones because they end up inside the tendon.
Yeah.
The last thing I'll say on the high volume injections is they're only effective with cortisone. So that's been shown repeatedly. So actually, it's the cortisone. It's not the high volume. We're not stripping the nerves or doing anything. So again, it's about being really honest with our patients about what we are and aren't doing. That is basically a cortisone.
Yeah. Is there any research to say it does increase the risk of rupture if you do have cortisone?
Yeah.
Yeah. Yeah. Interesting. Yeah, it doesn't happen that often, but sometimes we get that question. I guess it goes back to like what you said before. We're saying it's tendonitis. Perhaps that inclines someone more to think they need something to settle that itis down, which would be cortisone or anti-inflammatories.
Spot on. Yeah, spot on. So, just really highlights again for us how important our language is because, as a patient, that's a really logical step. I've got inflammation, how can I hit it with a hammer, basically, a big anti-inflammatory hammer, and that's a cortisone.
Yeah, yeah. I just had another patient this morning, and I feel like Kelly and I just asked any case studies, but it was a good scenario where this person had an Achilles tendinopathy, and they'd been currently running 50 to 60 kilometers a week, and they saw me today for the first appointment, and they were really concerned that I was going to say to stop running. And things hadn't, things hadn't gotten any worse. If anything, they'd been a little bit better. It's like, great, you haven't tried, so wasn't doing any resistance training, wasn't in a high pitch shoe, all these things that we could modify. And I was like, it's probably pretty likely that we can keep you running the same, probably take out a little bit of elevation or make it lower, and then we change all these other things and get you doing some other things. And it might be likely that we don't have to change that. However, she was still getting some discomfort. It was only a 2 to 3 out of 10, and it wasn't getting any worse the next day, and it was pretty stable. How do you posture that to people as 1? 2, is that the right thing to say? And 3, why is it okay to have a little bit of pain with tendon rehab and also with activities where we're using the tendon, like running?
I love that. That's a really thoughtful approach. So it's not black and white. Can I run? No. So basically, there's a couple of really great elements in there that I want to pick up on what you said. The first thing is for stability. We're really keen for tendon symptoms to be low and stable. They actually don't need to be 0. So if someone's tendon symptoms are 2 every day in the morning and or their stiffness lasts for 5 minutes and it's, they're running, 60 kilometers a week, that's a happy tendon. That is a tendon that is tolerating the load that you're putting on it. You don't need to rest that person. If you've got someone that the day after they run, they're a 7, that's your tendon saying, I'm not so happy with you. You are overloading beyond what I'm capable of. And they will continue to spiral downwards unless we do something about that. So the decision to run or modify aspects of running like frequency or volume or hills should be really individual. Because if you have someone with, say, a hamstring tendinopathy, they might be able to run flat but not hills, but you've kept them running. So that the things that I look at, Blake and Kelly, are the stability of their symptoms and also their just, a quick and dirty check of their capacity. So if you have someone with Achilles tendinopathy who can do, 25 calf raises, would we like their capacity to be a bit more? Yeah, we could, but we can probably get that up in parallel with keeping them running. There's a lot of brilliant effects of keeping people active, and the more we take them off stuff, the more we've got to add back in. So I'm always looking for what can we keep in. And that's true even within in-season. So I might say, okay, we've got to take someone off deadlifts for their hamstring, but what can we add in, that's in hip neutral? Or what elements of their loading can we keep in? So I love your approach. I think it's really thoughtful. And I hate hearing you can't run if you've got Achilles tendinopathy. It's actually much more nuanced than that.
Mm.
We know that low and stable symptoms are really safe, and that's not just true of tendons. We did a great study with Dr. Jack Hickey. So I was one of his PhD supervisors, and we looked at hamstring strain rehabilitation, and we can have some, low and stable symptoms during hamstring rehab that are really safe. You actually don't need to have zero pain.
Mm. Yeah, and I guess just just advocating that to patients, because I always get worried sometimes, because it's always I find it's easy for me to say, like, it's fine to have a little bit of discomfort, but it can always be difficult for the person who actually has the pain, because they're the one living with it. They're the one that's come to see someone. So it's good to hear that's on the right track, that it is low and stable. I like those two words, because it makes them just think of something where, if it's not, perhaps they need to take it back a little bit, but otherwise it's safe to load it.
They need to know if it's low and stable that it's safe. That's a really important message. And often even with an athlete in season, for example, you might say to someone, it's really difficult to have you completely pain-free in season. But if you're doing everything that you want to do in season and performing optimally, and you have low and stable symptoms, are you happy with that? And it's actually asking them and getting them to have some empowerment, some autonomy over the decisions. Some people would like to have zero pain. And for the people that I see that would like to have zero pain, we say, okay, well, we're going to need to take out your running for a while. Are you okay with that? No. Okay. So are you okay with low and stable symptoms? So it's a really individual discussion. And as I said, for clinicians out there, think about what you can modify. Can you provide more time between high tendon load? Can you manipulate their frequency? Can you modify volume? Can you modify hills? I don't muck around with people's running technique. People run with quite an automated motor pattern. So what I try and do is give them the capacity to run with what their brain, drives as their motor pattern, but I will modify aspects of their external training load if I can.
Yeah.
Ebonie, I'm going to pivot a little bit here, because sorry. I would love to ask you a little bit around patellar tendinopathy. I know that patellar tendinopathy seems to happen a little bit more in the stronger jumping athletes. Can you speak to why that is? I always find that a little bit tricky to get my head around, especially when I have gotten into a bit of a habit of explaining, a tendon not necessarily coping with load, and then I'll test the athlete, and it will be like their stronger quadricep muscle that's has the patellar tendinopathy versus their non-dominant side. And I would love to hear your thoughts on that.
So Kelly, you've just described the jumper's knee paradox. And I say to athletes, our best jumpers get patellar tendinopathy. That makes them smile a little bit, because then they feel like they're of the elite nature. So what we know is that in order to put really high load through your tendon, you actually need to be a phenomenal jumper. So the paradox is that our best jumpers jump more, because they're probably picked for more teams. They might jump 300 times in a training session because the setter is constantly getting them to practice their spike. In volleyball, they're likely to be in basketball, they're likely to be the athletes that are really agile and do lots of really fast lunging change of direction. So we know that the athletes that get tendinopathy are those that have the best springs. So you're right. What we see is quite a phenomenal ability to be able to get tendinopathy. That's who gets it. What we also know is that they do have some inhibition, and they actually do have a deficit compared to what their capacity would be. So even though they're our best jumpers and we can see really good strength on that side, when we do interventions that might reduce their pain, we see an associated reduction in inhibition and an improvement in their strength. So even though they're strong, they've actually still got inhibition. Does that make sense?
That's
Yeah.
odd.
Yeah, it does. And then the other thing that I've heard in relation to patellar tendinopathy is it actually gets more stiff in the presence of tendinopathy opposed to less stiff, like in the Achilles. Is that true?
Yeah, it's a good question. And the thing we've got to be careful of is how we talk about stiffness. There's the clinical sensation of stiffness, and then there's the stiffness within the tendon, which is a kind of physics, description. Then you have, muscle tendon stiffness, then you have limb stiffness, and everyone uses those terms very interchangeably. What we actually want for tendon capacity and for function is actually a really stiff tendon. And I'm talking about that in the physics sense. People get mixed up because they talk about tendon stiffness in a negative way in relation to the clinical feeling of, oh, my tendon's really stiff. But in terms of function, we want a really stiff tendon. Now, the research in how to measure stiffness is really complex. People try and do different, measures of shear wave or different. It's just really, really complex stuff, and I don't think we really understand a lot of those changes.
So you're
That's
saying
a very
you can't
roundabout way of saying we don't know.
Yeah, you can't just measure stiffness with your hands like some people.
No.
When you feel the tightness, you're massaging it.
Would agree. Yeah.
And what with I wanted to, I guess, knowing all the, yes, that's with any pain or discomfort, all the factors that can influence pain, does the management change with tendons when the pain is more centrally driven?
How do you know if it's centrally driven?
Yeah, good question. Yeah.
I love it. She nailed you. So it's a really good question. So what we see in tendinopathy is a really close relationship, despite how persistent it is. We see a really close relationship between load and response. So as best we understand, tendinopathy remains quite nociceptively driven, but we'd be mad to say that the brain and spinal cord don't know about it, because we see changes in the brain with tendinopathy. So what we need to do is, everyone deserves education. What we need to avoid is classifying people into persisting pain or nociceptive pain and assuming that what we do is reserve, good quality education and hands off and all the rest of it only for persisting pain. Everyone deserves to understand the 4 questions of self-efficacy. So this is from Professor Lorimer Moseley. People want to know what's wrong with me in a way they understand. They want to know, what can you do about it? What can I do about it? And how long will it take? So in tendinopathy, I might say something like, so your Achilles tendon is quite sensitive, and what you're currently doing is more load than what you have the capacity to do. So what that means is every time you go for a run, you're paying for it for the next day. So what you need to do about it is, the best research we have shows us that we can improve your capacity. We can get you stronger. We can retrain your spring. What I'm going to do about it is help you. I'm going to help guide you through your exercise program. I'm going to teach you when to listen to your tendon. You're going to know all about tendon load, what your tendon does and doesn't love, and we're going to get you back to everything you want to do. How long is it going to take? Well, I'm going to base that on my objective assessment. If you can do 6 calf raises and you want to run an ultra marathon, then we're going to need months, because we're going to need to improve all of your strength measures and retrain your spring and then get your volume up really high. If you're an older person and your capacity and you just want to walk around the block, then those time points are closer together, and I can give you a more kind of, accurate view of how that looks. So I think the key thing is to make sure that our education is really individualised. Whether or not someone has central sensitisation in tendinopathy, what I'll say is everyone deserves education, and we shouldn't be poking tendons anyway. We should be quite hands-off in relation to that as a diagnosis, but also a monitoring tool. So yes, they're sort of touch, they're peripherally sensitised, but it doesn't change what I do because I don't poke tendons anyway.
Yeah. Yeah, nice. And we'll finish up with we have one listener question. Well, we had many listener questions, but I knew that we would go through. Someone had asked do we have any research on what, and this is for the Achilles tendon, what exercise is the exercise that loads the Achilles tendon the most in the sense of fast rates of loading? Like, is it hopping, death jump, side to side, bounding? Do we have anything on to know which one?
Yeah, so Professor Craig Purdom actually mined a whole lot of raw data and put together this brilliant slide that I always show when I'm presenting on the Achilles. And he showed that the lowest rate of loading is like double leg pulses. Then you can move into seated calf raise. Then you move into standing calf raise. So there's slightly increased load on the tendon. The highest tendon load is sprinting. Wow, and really, so as you increase the rate of loading, that is higher tendon load. So the faster you go, the more load on the tendon, or the increased rate of loading on the tendon. So running at different speeds increases the load on the tendon. Different, skipping and hopping drills. So what you can do is take that question and go, fantastic, you've just outlined Achilles rehab for me.
Yeah.
They need seated calf, they need standing calf, they need, progressively increased skipping speed drills. You can use stairs, using a metronome, so you're systematically increasing the pace of their loading, all the way through to someone who needs to sprint. That's how I reload them.
Nice, the blueprint. I like it. But as you said, it's all individualized. But that's good. That's good.
But some concepts are good around how to do it. It is individualized, but the concepts can be used across people. Yeah.
Awesome. Ebonie, thank you so much for coming on. Those 59 minutes flew by. That was, a lot of great pearls of wisdom. Thank you again for coming on. And for people to, keep up with what you're doing. I know you're doing a course in Sydney, a symposium. We were going to go, but we're going to another course the week after. Is that where what's the best way to keep up with what you're doing? Just follow you on.
It's a good question. Well, I'm not on social media, so you won't find me. I've got a Twitter account, but I don't even know the password, and I haven't checked it in years.
You're going to log on with like 40,000 notifications, I'm sure.
I'm never going to log on, so I'll never know. So I think it's, the best way is probably through maybe the Trobe website, but social media is good for promoting, different free and paid opportunities. So that's probably a good way to just keep up with tendons in general, because there's lots of great people doing stuff in tendons, and it's good to hear different voices. I don't think there's one answer. I don't think, everyone needs to do it exactly how I say. I think there's lots of capacity for that individual clinical reasoning that you talked about before. So I think listen to lots of different people and gather evidence and work out how the next bit of evidence you can integrate into your model. Don't just throw everything out before, because you're never going to get a recipe from the research, because the person in front of you won't be like the person in the research study.
Don't just read the abstract and take that information from there.
Spot on.
Awesome, Ebonie. Enjoy your weekend, and thank you so much for coming on.
Thanks for having me. I really enjoyed the chat. It did fly by.
Thank you so much.